DRA stands for diastasis rectus abdominis. It's actually a growing concern of new moms in the past several years, and there's been a lot of information out on social media, on the internet, and the science really validates that once we get to about 30 weeks of pregnancy, our abdominal wall muscles, the ones that sit in the front, the most outermost abdominal wall muscle, slowly start to separate. And by the time you reach full term, between 38 and 40 weeks of pregnancy, 100% of women will have a separation of some sort of the abdominal wall. The abdominal wall is a layered muscle. The most outermost muscle is called the rectus abdominis, and it runs from your sternum all the way down to the pubic bone, and it's got two sides, two muscle bellies. And when we're at our utmost fitness level, it is what we call our six-pack. The next layer in are your obliques, and we all know about the internal and external obliques, so there's two layers of those. The one muscle that tends to get forgotten in our abdominal wall is the deepest one, and it's called the transverse abdominis, and it runs thus transversely. The muscle that separates when we get to that 30 to 40 weeks of pregnancy is the outermost muscle. There's a connective tissue or a fascial attachment that kind of holds those muscle bellies together, and as the belly expands when the uterus is growing, it has to come out, but those muscles can't go out as far as we would like them to, and they slowly start to widen. The abdominal wall itself is not painful with a diastasis recti in 99.9% of the time. That's not usually something that they experience discomfort here. Where a woman who has a diastasis recti may experience pain is if they have instability in their spine or their pelvis. For example, remember I said the muscle belly attaches down to the pubic bone. You've got one on either side. And if the muscle wall isn't activating properly, you may get some separation here at the pubic bone. And that's not an uncommon finding anyhow when we're pregnant and coming to the end of our pregnancy. The pelvic girdle has to relax some so we can deliver the baby. Now, if our muscles don't regain strength at an appropriate time and this stays weak or unstable, a woman may experience discomfort here, or popping or clicking. The same thing could happen with the sacroiliac joint, and a lot of women who've gone through a full-term pregnancy sometimes will experience sciatic-like symptoms or pain in the low back butt area, and it's usually coming from this joint. And if the abdominal wall isn't working, all of those muscles, to be honest, collectively, that instability can cause some pelvic girdle pain. Again, it's not the abdominal wall that necessarily hurts. It would be more a joint or musculoskeletal issue. Again, like I said, every full-term pregnancy is going to have some of this abdominal weakness or this separation. But I find on average 6 weeks minimum, we're going to see some of that separation. However, 12 weeks is more common in my opinion, and I tell some of my ladies that they give themselves a year before they basically accept something as their new normal. First of all, the first question women will ask me is, can I put a binder on? And I say absolutely. Right after you have the baby, you can take basically what looks like a Velcro type, somebody who just have had maybe an abdominal surgery, binder that goes around the abdominal wall. And it basically holds those muscles in place while you start getting back to life, because they're starting to function now. We don't want you to function and carry on your day with your muscles kind of hanging out here. However, you don't want to be in a binder for a whole year, maybe 6 weeks, sometimes up to 12. So it's not necessarily just about closing the gap. We need to retrain the abdominal wall to fire properly. We need to be able to learn we want to teach a woman how to recruit her muscles properly so she can create that stability in her spine and in the pelvis. a very simple test for a DRA is if you lie on your back with your knees bent, and you basically need to take 2 to 3 fingers and you put them perpendicularly into the abdominal wall. So if the patient is lying down, and their belly button, between the pubic bone and their belly button, I'm just going to gently place my fingers right in the center. When they're resting there, right above the belly button, about an inch or 2 above. And then I'm just going to have the patient gently do a little crunch. Again, I'm not going to teach that as an exercise, but that will show me if the muscles are separating. So what I feel often is when I get my fingers down, you have to push down a decent amount, I'd say an inch or so, into a soft abdomen. And as they sit up, you'll feel the edges, hopefully, pulling your fingers together. If that doesn't happen, and as a clinician, sometimes I have to move my fingers a little bit and I'll feel these edges out here, that to me that's too wide. Anything over 2 fingers is too wide. If you suspect you have a diastasis recti, you can get in to see a physical therapist within 4 to 6 weeks postpartum. What is ideal nowadays is you can see a physical therapist without having to have a referral from your primary physician or your obstetrician. Our team of physical therapists here at Pro Healthcare will always loop your obstetrician in. So if somebody came to me to have their abdominal wall checked, they can call, get on my schedule, make an appointment. I'll do an evaluation. And if I feel that further care is needed beyond an evaluation, I will start prescribing exercises and we'll set up that patient for usually what ends up being weekly sessions. And then I call the obstetrician and let them know. I'll forward that evaluation on so they're aware that they're coming. During pregnancy, no, there isn't. If you do know, let's say in a prior pregnancy, you did have a DRA, I would suggest working with a physical therapist during that this upcoming pregnancy to guide you through safe exercises so that we don't make that pending DRA come on sooner or worse than it could be. Upon an initial evaluation, once I evaluate how the patient is using their muscles and I feel confident that they now know how to recruit the muscles properly from the inside out, the next week or 2, I strongly encourage they just use that brace anytime they're lifting the baby in the carrier, anytime they're placing the baby in the crib. If they have to lift a toddler, if they're pushing or pulling anything, they'll see an immediate difference. They'll see that abdominal wall start to flatten. But so again, the goal is not necessarily to totally close the split, it's to re-educate the muscles, and in time that split will improve.